I consent. Continue.
Good evening. We're going to wait just a couple minutes to get started.
Recording in progress. Recording in progress. Recording in
There you go.
Dr. Jaguar, you're muted.
Welcome, everybody. I'm Jeff Jaguar, and I'm the host for this series of cancer prevention and wellness presented by the Cancer Survivors Park Alliance. Each month, we try to equip our audience, and the audience is virtual for the time being, but hopefully we'll develop some kind of hybrid model pretty soon. Each month, we try to equip our audience with capabilities via knowledge for prevention and lifestyle to help you live better, whether you're dealing with cancer or whether you're trying to prevent cancer, and whether you're trying actually from the standpoint of some of the lifestyle factors we talk about of just preventing any kind of chronic disease. We used to have these at the park and the Center for Hope and Healing, which was very nice, but it happened at a specific time on a specific night of the month, and sometimes people, because they're busy, couldn't always get there. So COVID has made us pivot, as it's made us all pivot, and I think we're getting a better audience now, but hopefully we'll be able to do something live and record it in the near future. Just a few housekeeping things. This will be recorded, so it will be on the cancersurvivorspark.org website, probably in 24, 48 hours for you to listen to it again. You're muted now, but can certainly ask questions via the chat room, and Laura Caroline will send those to me. So it's supposed to be a little bit of a discussion, and hopefully it'll stay that way. So we're really honored and excited to have tonight Dr. Brian McKinley. Dr. McKinley has been in the Greenville area as a surgical oncologist for a number of years now. He trained at the Sidney Kimmel Cancer Institute at Thomas Jefferson University in Philadelphia. He can do it all, but has really restricted his practice more from the standpoint of breast surgery and breast oncology. He is a very good speaker and somewhat of an amateur comedian, and I'll probably let you decide whether it's more amateur or comedian. But Brian, with that little introduction and a little bit of an insult, I guess, I'll let you take it away.
You ruined my opener. I was gonna say, don't tell my wife I can do it all. I'm getting away with only doing a couple things. So
right. Yeah, she already knows.
Well, thanks, Jeff. I appreciate the opportunity to come here. I think this is the first time I've been on so many Zoom calls, but I think this is the first time I've ever actually tried to give a talk. And I remember the first time we we actually, for our residency program, had a speaker give a talk. It was a logistical nightmare. And so far, this is going so smoothly. I'm almost nervous to say anything else will jinx it, but
Don't jinx it.
I wasn't gonna.
All right.
But I did want to kind of go through some things with folks. And I've given lots of different talks over the years, and I apologize if you've seen one of them before, and some of it seems familiar. Certainly, we always talk about some stuff that's been around, so we always have to go with something old. Hopefully, we'll give you something new. And I always borrow stuff, so there's something borrowed, and there's something not blue but pink, obviously, because we're talking about breast cancer. And pink's the color. So that's my little funny. Usually it's in October, so it kind of works a lot better. All of downtown is pink and everyone's thinking pink, but in July, I guess this is just a substitute for the hot sun here in Greenville. So let's get going. I think again that the plan for today, we are going to go over some old but true stuff. I think when we're talking about, preventing anything, the first precept is to kind of get to know what you're trying to prevent to figure out how to do it. So we'll talk about breast cancer and breast cancer epidemiology and go over some facts. Then we're going to talk about breast cancer prevention and in some respects prevention of medical things in general, and really kind of try to highlight what we can and cannot offer folks. Because I think sometimes there's a little bit of a kind of a misperception of what we're talking about when we talk about prevention. But first, if you'll allow me a digression. Who remembers Jim Fixx? Can we do that little clapping thing right there? We don't have to do that, but
Yeah.
I don't know.
I had the book.
You had the book, yeah. So there you go. So Jim Fixx was famous in the late 70s and early 80s, rather. And he was famous for his promotion of the value of running, and he was a fanatical runner. What I think a lot of people didn't know maybe that, as a Mensa member, he was very bright and he was an author, not only of those running books, but he also wrote puzzle books. So a very active mind. And in his kind of early adulthood in 1967, he was a 2-pack per day smoker and weighed over 200 pounds, not really in good shape, but he started running. And within 10 years, he had trimmed himself down to 154 pounds. He not only ran avidly, but wrote about it. He had stopped smoking, and he was, by all measure, picture of health. He was the darling of the media. He not only wrote one book, the complete book of running, but some follow-up books. He was literally world famous for this work. So really kind of like, the ideal kind of clean living kind of thing. He took control of his life and really.
And this is what we say all the time. This is lifestyle.
And there you go.
Right.
In 1984, he died of a heart attack on his daily routine run. Just basically keeled over, dead. Really tragic and shocking. And I can remember I was 17 at the time, and I can just remember like there was a lot of people like said, "Oh, this is terrible." Then a lot of people, "Oh, he's a fraud," and I just thought, "Wow, this is tough." The poor guy did all this stuff, and then this happened. So I think it's important to kind of understand what we can and can't offer in the world of health in general, in prevention and health promotion, and specifically in breast cancer prevention. So we can offer lots of information, and based on that information, kind of talk to you about strategies to reduce risk. And really, compared to when I was a resident in 93 through 98 and now, we have so many tools at our disposal to do this. But what we can't do is offer guarantees. And I think sometimes when we talk about risk reduction and prevention in medicine, people hear the prevention and they kind of think more in a kind of a colloquial sense of prevention, like making something not happen universally or uniformly. And that's not really what we're talking about. What we're really talking about is risk reduction. So we can't give any guarantee that something bad isn't going to happen. So if we just start talking about breast cancer facts, it is really a common cancer. I don't think anybody doubts that. And from an epidemiologic standpoint, we see that in the United States, each year, breast cancer is the most commonly diagnosed breast cancer, with about 250,000 cases of what we call invasive breast cancer a year. That's the life-threatening version. There are also about 60,000 or so non-invasive breast cancers diagnosed every year. So about, over 250,000 women easily are subjected to this each year.
And Brian, we always call this the Virginia Slims slide too. So
is that why?
if everybody remembers Virginia Slims, I don't even know if they have Virginia Slims anymore, but it was marketed as the first cigarette for women, and their marketing slogan was "You've come a long way, baby."
Yeah.
Because in the past they didn't allow women to smoke, and so you see in the incidence column there for women that lung and bronchial cancer is number 2, and it's probably blotted out a little bit by the red mark around the breast cancer, but number 1 as far as the killer of women is lung cancer.
Yep, hide behind that red oval. That's correct. So as an aside, I'll just tell you that in my research fellowship as a surgical oncology fellow in Buffalo, I couldn't pipette stuff and splice genes and do all that stuff. So I actually did epidemiology research, and they stuck me with a guy. I was like, wondering why they stuck me with this guy, but he was a health behavioral scientist, and his big thing was tobacco control. If you ever want to, I will come talk to you forever about tobacco and the evil in the tobacco industry. But this guy actually, who subsequently relocated to Charleston, I think he might be still down there at MUSC, was a leading advocate for tobacco control. Anyway, that's an aside, but you're right. The smoking is kind of crazy. So, but there you go. I mean, when you talk about cancer in women, it's right up there at the top of the list. It's something that bears a lot of attention in terms of the extent of it, the public health problem it causes. But truthfully, here's the other side of the coin that I think we miss sometimes. It is relatively an uncommon diagnosis. If you look across the population, while through 6 degrees of separation, we always kind of hear like we know somebody. The truth is, the vast majority of women that are born in this country and live to age 90 will not develop breast cancer. In fact, only 1 out of about 8 will. So if you were a gambler, you'd probably like those odds. But there's no sense in kind of being gamblers with our health. But it is, I think, healthy for perspective to kind of understand that breast cancer diagnosis is not an eventuality, and it is something that we can minimize the risk for even further than this already low risk to start off with. Certainly, what we're trying to avoid is getting into this stage of the stage. I didn't mean to do that. Getting into this part of the debate of having cancer diagnosed, but clearly the cure rates depend on the stage of cancer. And the stage is our jargon term for a description of how far along the cancer is or isn't, with the idea being that the earlier in the cancer's evolution that you catch it, the better off you will be and the higher the cure rates will be. So a lot of what we hear about in breast cancer is about kind of, in a sense, this type of prevention, which in the epidemiology world really isn't prevention at all. It's just kind of getting to the scene as early as possible. It's this stuff called secondary prevention versus primary prevention. And what I'm hopeful to talk to you a little bit more about today, I think, is more primary prevention. But in terms of cancers themselves, once they're diagnosed, we're hoping that we caught it at an early stage. This is just an example. In this bar graph here, we see that the stages of cancer, and there's 5 of them, 0, 1, 2, 3, and 4. The stages of cancer are really related to the likelihood that you're surviving. So the dark purple is the percent of women alive at 5 years. The light purple is the women alive at 10 years after diagnosis. And you see in stage 0 cancer, which is the non-invasive form, almost every woman is alive at 10 years. And the ones that aren't probably, or actually almost all of them, would have died of some other problem. But you can see in invasive cancer, even the earliest stage invasive cancers, the survival figures suffer. And as you get into more advanced cancers, the survival rates and the percentage of women we're able to cure drops with the increasing stage. So this is clearly what we're trying to avoid getting on this graph when we really talk about breast cancer prevention. And that's, I think, the thing we need to push past the idea of early diagnosis, which is important, and try to really get people thinking about more primary prevention. Because the breast cancer survival rate is 100% if it's never diagnosed, if it never happens, right? And so I really think we are really kind of on the front end, on the dawn of our ability to kind of prevent diseases like this. And so that's why we're turning our attention with a series like this towards true primary prevention. And really, any prevention should begin with a risk assessment. Now, technically speaking, if you were really forward thinking and if you were a big government person, you would really design a health system that hardwired some of this stuff into our lives and our lifestyles. We're not quite there yet, and I don't know that as Americans we'll ever be there. But if we get beyond the idea that social engineering could have a big effect on this, and again, if we want to talk about tobacco control, I can tell you how my old boss did a lot of that. But really, if you want to prevent something, the first thing is you have to learn about it, and you have to do this thing we call a risk assessment. So what is the risk? Well, we already know that the risk for women is about 1 in 8, but that is the average risk. And if you think about it, every average is a compilation of data points that are around the average, below the average, and above the average. And so as an individual person, it really doesn't help you one little bit to know what the average risk of breast cancer is. What you really want to know is what is your risk as near as we can tell, because it's your risk that's going to probably drive the whole process of how you approach it. So my risk of spraining my ankle in the NBA finals is essentially 0 because I'm not going to get on the court and I don't follow any NBA basketball team. So I'm never going to go to a game and twist my ankle walking down the steps, right? So the risk of something, the absolute risk that it might happen really will drive a lot of it. But the other thing is, what your personal approach to risk might be. I think this is something that's really been fascinating to me because I loved my training both at Jefferson and residency and in fellowship, but it really was kind of like, we were like getting loaded into a gun and being shot out at the community. Like they were teaching us all this stuff and we were going to go do it to people and for people. We were going to tell them this is how you do things and this is how you cure things. And when we have something, this is what you do. And I've just been fascinated over the course of my career how some people say, it's nice, but no, thank you. And so this kind of, I guess, tapestry of approaches that we have in our country to various things, but especially health and healthcare and what people will or won't do, I think has been fascinating. So really, the thing about prevention is what can you learn about your risk level? And then what do you want to do about it in terms of your approach to risk? I mean, we think of risk, I think, in a way that really is not as helpful as it could be when it comes to breast cancer prevention. We think of risk as risky behaviors, right? If you're going to drive your car fast, if you're going to run with loose women and fast men and guns and pickup trucks, you might end up kind of like this chalk outline. But really, the risky behaviors that we kind of think of as being risky are a lot more mundane when it comes to health. It's never really risky for me to sit on my couch, but that lack of exercise is getting to me. And occasionally puffing on a cigarette, aside from burning your fingers if the match goes. Alcohol is risky, but a part of American life. And man, my favorite thing to talk about is food all the time. Those are what really contribute to a lot of the risk and keep us from being in the sweet zone of good health. So we have to kind of learn to get a sense for how those impact our risk, because truly, to lead a good life, you really kind of need to have good health. I wouldn't have said that as I was super young, but having watched what my parents went through over several years before they died, I really realized that the measure of their health really and the quality of their life really was impacted kind of as their health deteriorated, and I would say prematurely. They were fairly young. So here's the other thing about risk is it's a very abstract kind of concept really at its core. If you put your hand on the hot stove, it hurts and you pull it away and you're not likely to repeat that action very soon. but the idea of risk is really kind of relegated to this probability statement. Well, a certain thing might happen or it might not. And for people, in terms of the ability of the thing to motivate behaviors, this kind of abstract is sometimes very difficult to use to get people to do things. We know a lot about risk factors for breast cancer. You know, these are the things that kind of make breast cancer more or less likely to happen. And in terms of risk factors, the two most important ones are getting older. So the longer you stay around, the longer the chances you might be one of those 8 people, 1 in 8 people rather, that get breast cancer. And then your gender. Although some men do get breast cancer, it's pretty uncommon for men to get breast cancer. Really, by and large, it is a disease of women. And I'll share with you one of my pet peeves come October is when people start talking about breast cancer, and there's a guy that wants to talk about breast cancer and males' breast cancer risk. And I'm like, I don't want to dismiss anybody, but really, this is a disease and a healthcare problem for women. And insofar as women are the center of our existence in society and they do all the hard work, it does affect them, but it's not a disease that men generally get very commonly. There are all these other things that play into risk for breast cancer. A woman's reproductive history, when she started with menstrual cycles, ended, and babies and how soon she had them. The family history, like what did other people in the family come down with, especially when it comes to cancer. So women who have a family history of breast cancer or who have a family history of ovarian cancer and other cancers, they're at higher risk. And then even to some extent, the ethnicity of a person plays into not only risk factors or risk for getting breast cancer, but also, you know, when that breast cancer might happen. So those are important factors. Now, I will say this to everyone. I want people to take this away. Even though we think of family history as an important risk factor, please tell all your friends and neighbors after this talk that most women that are diagnosed with the breast cancer in this year, every year, and when I say most, I don't mean 51%, 75%, maybe upwards of 80 in some studies, 80% of women, 75% of women who are diagnosed with breast cancer have no family history of breast cancer before they were diagnosed.
Brian, can you go into that reproductive thing a little bit more from the standpoint of when they start having periods, menopause, you know, actual having pregnancies and that sort of thing?
Yeah, so I'll go into it, and then I'll hopefully end with a I hope a clincher that says forget about all of it. But so here's the thing: the general idea is that we think that the longer a woman has unopposed estrogen stimulation, that the more at risk she is for having breast cancer. And so that means that the earlier she would start her menstrual cycles, menarche, the earlier that would be, and then the later she would have her first child, or if she never had a child, that gap in time seems to be related to the risk for getting breast cancer. So the longer it is, the higher the risk. There is also evidence that after menopause, certain types of hormone replacement medications increase the risk for breast cancer. And so those are things that, like, we were taught to ask those questions when I was a resident, and we would ask them, and the woman would go, "What does that mean?" And you'd kind of go, "Oh, it means your risk for breast cancer is high." And you kind of go,
Yeah.
That was like fire in a crowded theater, because
Thank you very much.
What do you mean my risk of breast cancer is high? And I go, I don't know any more than that. I'm sorry. And then, like, that was the end of it. So ultimately, those things have an impact, but we don't really know how to dial in and say, if you had your first period at 12, your risk is this percent, versus if you had it at 16, or if you had your first baby at 20. So ultimately, this information nowadays gets fed into risk prediction models that we'll talk about later. And I think that's another important point, along with family history and reproductive history and age and gender, is that you can't focus on any one aspect of your history to say, oh yeah, this means I'm not at risk, you know, and check it off and get out of it. It really is kind of a collective, really poorly understood combination of factors that kind of leads to breast cancer. So is that good enough?
You know, that's great. I mean, I've heard some professors say that, you know, the earlier in life that you have a pregnancy, the better. And we would do well if we could simulate a pregnancy in teenagers. And maybe that's the social construct you're getting to in the future.
Yeah, I mean, yeah, certainly. The I guess my take on that is, and this part of me, I would say a part of me, a lot of me is informed by the fact that I'm a surgeon, right? So I don't really want to think long and hard about too many difficult things. I want to get in and fix a problem, right? So to kind of like, for me to kind of untangle all those reproductive factors is a little daunting. So intellectually, it's very easy for me to say, well, it is what it is. Don't worry about that, ma'am. Let's just put it in the model. But I think some really smart people might be able to kind of look at that more as a part of the problem that could be solved or at least manipulated. So that's interesting. I also have in there biopsy history. Having had a breast biopsy in the past actually is associated with higher risk, and specifically, depending on what that biopsy shows, can be very important in terms of its impact on the risk for future breast cancer. So that's kind of, I mean, right here, this slide is where we were when I was a resident in the mid to early 90s. We kind of have made a ton of progress in the last 25 years. So hopefully we'll talk about that. Here's one of the problems though. Of all those risk factors, there's almost never really a smoking gun. We can almost never kind of look backwards and say, you got breast cancer and oh, here is exactly why. We can do that in some situations, but the number of times percentage wise we can do that adds up to a very small percentage of the women that get breast cancer. So women that have an inherited cancer susceptibility syndrome through abnormal genes, specifically a mutation in something called BRCA1 or 2, their risk is so high that when they get breast cancer, it's almost always because of that mutation. There's another scenario where women who were treated at a young age, somewhere between 10 and 30 for lymphoma and got radiation to their chest, they have a very high risk for breast cancer. So when they get one, it's kind of presumed that it was because of that. But short of that, the smoking gun almost never exists. It's really something that happens, this breast cancer development in a person, really very slowly, quietly under the radar, and it's hard to get a beat on early on. So what do we mean when we say risk stratification and prevention? I touched on this a little bit earlier. What it really means is that we're not preventing cancer like pulling a big bubble around someone and saying it will never happen to you. But what we're trying to do is by assessing all those things we talked about in the risk factors and the histories, trying to separate patients away from that 1 out of 8 blanket assessment for everybody into higher risk categories and average or lower risk categories. Because when you can separate people out meaningfully into those that are at higher risk for something and those that are lower risk for something, then you can start to take different strategies towards those groups that make sense for that level of risk. So I'm never going to get an ankle sprain in an NBA final. But if I got tickets, if somehow Dr. Jaguar pitched in for tickets and we flew to one of the finals games, I might wear an ankle brace and maybe, not drink as much beer during the game. So I shouldn't have said that probably. I don't drink beer at all. So
Right.
the Irishman, right? Wink, wink.
Right.
But that's the idea. So what we're really trying to do with the risk assessment is look out among the collectively the group of women and find really the ones that are higher than average risk, and then basically talking to them about the proven interventions for those, specifically with respect to more intensive monitoring of their breasts for anything going on, and then also to apply treatments that can lower their risk for breast cancer. And then ultimately, this is where I would really anticipate that we're going to be able to go, hopefully in the not too distant future, probably not before I'm out of medicine, but hopefully before I'm, checked out of this world, is really start to look at, be able to offer something to every woman, even the average and low risk group of women. Because even among the average and low risk groups, there are still breast cancers that come up in there. And believe me, they don't feel better about things just because they started off in an average risk group and now they have a breast cancer. So we really want to be able to bring something to everyone if we can. It turns out that right now, the most impact we can have is in this high risk population. So how do we talk about risk? I think this is very important when it comes to, first of all, getting people to do things, but even before that, getting people to listen to you, because some people don't even want to talk about risk. But if you start off the conversation and end the conversation, anybody with "you're at high risk, ma'am," then it really is like it was in the 90s. And we kind of said, thanks for your time. Good luck with all that. We could also kind of use kind of these relatively, they're quantitative in a sense, but they're not real specific. Your risk is triple average or double average or quadruple average. Well, again, for the individual woman, that's not particularly helpful, because triple average sounds terrible. It sounds like they're almost definitely going to get breast cancer. What most of us favor is this kind of giving women, if they're interested, and we're able if they're interested, more of a quantified, specific risk estimate that actually describes their absolute risk of getting breast cancer over the course of their lifetime, starting at from the point where you meet them. Another strategy, which really sometimes we have to take, is to just say nothing, because some women just aren't ready for this discussion. I think most of the time, this say nothing, unfortunately, though, really happens because there are so many other things that doctors have to take care of for folks that they never get around to this. Which is, I think, not to make too shameless a plug for what we're trying to do here with our breast cancer prevention clinic. I think it's one of the nice things is that we have time in our breast cancer prevention clinic, which is, it's actually headed by Dr. Jaguar through the Center for Integrative Oncology and Survivorship in our Cancer Institute. We have the time and the expertise to go through that in depth with someone. I feel nothing but empathy for the primary care doctors, who they have so many things to cover for people in terms of making sure that everyone's getting their vaccines, everyone's getting their cholesterol checked, everyone's getting their sugar checked, everyone's got their blood pressure control in mind. It's hard to get around to everything, and sometimes they can't do this every year for everybody. So, but communicating risk levels is an important part of this. And the other thing is, how would you, as an individual person, learn about your risk? Well, I mean, you could take it up upon yourself and research, and you could actually get a lot of good work done nowadays if you were pretty savvy about which websites you went to. You could also probably get tricked down some rabbit holes and realize, that you spend a lot of time on the internet for nothing. But another way is to just ask your doctor. And I always tell, this comes up often when I meet with a woman with breast cancer, and oftentimes her daughter is there, or her son is there and her daughter-in-law is there, and they say, what about me? What should I do? And I say, well, you've got to ask your doctor. That's your doctor should give you a breast cancer risk assessment if that's what you want. And I say to them, if they kind of go, huh? Like they don't know what you're talking about, because sometimes they might not know specifically what you mean or specifically how to do it. We have two vehicles within Prisma Health that can kind of help you do it. We have the Center for Cancer Prevention and Wellness, and we also have the aforementioned Breast Cancer Prevention Clinic. And these are services offered by our Cancer Institute that can really give you some comprehensive factual information about your risk for breast cancer. And in the CCPW, as we abbreviate here, they can even talk to you about risk for other stuff. In the BCPC, we focus pretty exclusively on breast cancer risk, maybe touch a little on ovarian and things like that. But that's kind of how I direct folks to learn about your risk. And I think, again, this personal attitude towards risk, are you going to be like the monkeys? Are you going to, cover your ears, cover your eyes, and cover your mouth and kind of walk away from it? It's America. That's okay. And for a lot of people, it's not the right time in their lives to be taking on this. You got to be kind of in a place where you're ready to do it. And I've met with many women over the years who say, I met with you a couple years ago, but we just had put my mom in a home and she was just stricken with I couldn't get my brain around it. And then they come back a couple years later and then we get them involved, right? Or are you like this guy in the bottom right, who I watched way too much TV when I was a kid, I realized growing up, but this Columbo guy, he would never let it go, right? I'm not going to do the imitation because it would be terrible, but Are you that person that really wants to track down the facts and follow them to their natural end to kind of help yourself and get more information? It really, and between Columbo and these monkeys, I've seen it all in terms of what people are up for. And this is the part I think that to me has been one of the more fascinating things. I just assumed coming out of training that I would be talking to a bunch of Columbos and I would tell them stuff and they'd be, okay, good, here's where we're going. Not so. I even found this slide, and I found it a couple years ago, and I thought it was really great. Like, this would be for the uber organized and detective type person, right? You can even kind of, talk about, the event of whether it's high probability or low probability, and what the impact is, and whether it's low or high. Essentially, this is what we're trying to help you do when we talk about all this stuff. I don't know many people that would make their own four box construction to kind of help through this, but this is essentially a big kind of pros and cons analysis, which I think a lot of us are a little more used to. That's way more organized.
And the purchase insurance would not be health insurance, it would be life insurance.
Yeah, right.
Yeah.
Probably.
Yeah.
And then I had the smoking gun back in there because I thought it was such a cool picture. But this is one of the risk stratification models that we use. We still use it, but it's changed. It's interesting too how all the software programs have improved so much that now they're so much more user friendly. Again, you can do all of this yourself and go to a very easy to use interface. This was a clunky, difficult to use interface, but it worked. And this was a model developed by two researchers from England called Tyrer and Cusick. And we still use this today. And there's a modified version up to version 8 that we use. And essentially what it gives you is an estimate of the likelihood that you would develop breast cancer within the next 5 years from this analysis or throughout your lifetime. And it would also give you some indication of the likelihood that you might have an inherited cancer susceptibility syndrome. And here's one of the printouts for that. So they give you a nice little graph. This blue line is the average risk for someone in your age category. And this red line, your personal risk, is, you can see here, this woman's risk separates quite a bit and is quite a bit higher than the population risk. So we'd be able to say to this woman, hey, average risk for your age would be that we would expect that 10% of women or so, if they live to be 85, would get breast cancer. But for you, women in your situation, that risk is over 1/3 or 37%. And over the next 10 years, it's about 1 in 6, 1 in 7, right? With these numbers, then, we can start to see whether and how this will impact a woman. For some women, they kind of say, okay, 63.6% no breast cancer. I'm good, thanks. For others, they say, whoa, that's something I need to sit up and take notice of. What are we going to do about that? Yeah, so what we do with it is, at the invitation of the patient, of course, is we share with them how we can approach the situation. And it really comes down to these two planks or two platforms that we use in this setting. One is we describe what we would call a tailored or intensive screening program for breast cancer. So among women who haven't been diagnosed with breast cancer, we think every woman 40 years and older should have, as part of her screening for breast cancer. And just so I'm clear on this, screening is a jargon term. It means applying a test to someone or a population of people who aren't having any problems in that area, but just to look for something going on. So with breast cancer, it means no lumps, no bumps, no nipple discharge, no real new problems with the breast. So I hope it's safe to say if you're having any of those problems, you need to get checked out separately, right, by your doctor. But if you don't have any of those problems, we would say that the average risk woman's screening should include annual mammography beginning at age 40 and an annual exam by a healthcare practitioner. That's called a clinical breast exam. And to the extent that a woman's comfortable, either self-breast exam once a month or just being cognizant of a woman's breast, her own breast. Self-breast awareness is what we talk about.
And Dr. McKinley, we may go into this further, but I mean, it's fair to say that from the standpoint of malignancies that we screen for, that we do surveillance for, the breast is probably the one we have the most, the greatest number of tools. And they're, you know, obviously a mammogram is not comfortable, but it's not overly invasive. And can you talk about some of the other screening tools that have developed in the last 5 to 10 years? And obviously there's lies, damn lies, and statistics, but a little bit about sensitivity and specificity to help people kind of, you know, deal with the 3D and the MRIs and that sort of thing.
Yeah. So it's a great point, a great question. So yeah, so I think in our country, mammography is the cornerstone for screening, right? It begins and ends with mammography from the perspective of the broad applicability and the success rates. And although it begins and ends with mammography, mammography is not the end all and the be all, right? So mammograms are very effective at picking up breast cancer, but they can miss breast cancers. And so when we talk about sensitivity, Dr. Giguere brought up that term, that's a statistical term that it's just like what it sounds like. It's how good is the test at picking up the disease? How sensitive is it? If you look out among a group of women and you know that 10 of them have breast cancer, how good is the mammography at finding those 10 women? And historically, that number has been around 80% sensitive. So that means about 20% of women on average will have breast cancers that won't show up on the mammogram. Now, that sensitivity is not the same for someone who's 40 versus someone who's 65. It's not the same in someone with dense breasts as in someone who has radiographically breasts that are less dense. But across the board, it's important to know that mammography is the best test we have probably to give to a lot of people, but it's not perfect.
And we just had a comment in the chat room about lobular not being necessarily picked up as well with mammography.
Yeah, absolutely. Absolutely. Yeah. So he's referencing a different type of breast cancer. Well, it's not, yeah, it's one of the types of breast cancer that, again, doesn't show up as well on mammograms as other types of breast cancer do. I think this is where it gets into it, like what we can offer you and what we can't offer you, right? We can't offer a foolproof screening test. We can't offer a guarantee that when you get a mammogram and you get that nice letter that says everything looks good, come back in a year, we can't guarantee there's nothing in there. But one of the reasons mammograms are designed to be done year upon year upon year upon year is because things can evolve and change. And so you have to keep getting them. So if you start with mammography, which was developed through the 50s and 60s and really came into regular existence through the 70s, there are some other tests, breast x-ray tests specifically, that I think have been used over the years, and I think they deserve a little bit of mention. I'm going to mention one literally to condemn it, and I'm not going to spend a lot of time condemning it, but I want no one to think that it's a worthwhile test. It's called thermography, all right? It's very intuitively appealing that you would get a thermogram, which checks the heat of the breast and gives a heat map of the breast, and cancers should be hot spots within the breast. It sounds so logical, but it just isn't true in terms of its ability to find breast cancers. And actually, thermography was part of one of the initial studies along with mammography called the Breast Cancer Demonstration and Detection Project. And it was shown then, and it's been proven again and again and again, that thermography is not helpful. So please, if you're at your golf game with your friends, your tennis game, or your bridge club, and someone talks about a thermogram and they're doing it because it really is good, tell them, please, McKinley said it's not so good. Please don't do it, right? So enough with thermography. The other test, so ultrasound is a very common test used in breast imaging nowadays, and people use it generally. We generally use it to solve problems within the breast imaging. Is there an area that we want to check out more? Does someone have a palpable abnormality? But people have that ability to look at the breast as a screening test. Remember, as a test to just look at the breast when there's not any problem. And the results are that you can find more cancers with ultrasound than just mammography alone if you combine ultrasound with mammogram. But that once you start to use ultrasound in everybody to screen everybody, you start finding a lot of things that aren't breast cancer. And so we have this problem that arises, and it's kind of a statistical problem called a false positive test. So the false positive percentage for ultrasound and breast cancer is high. So that means a lot more women get called back for more x-rays and then have to go get biopsy. So we don't really think ultrasound is a valuable screening test across the board. There are certain situations when we might use it, but not very often. And that might change as screening ultrasound gets better, to be honest with you. But right now we don't use it. There's another test called screening breast MRI, and you might have heard of MRIs. We use them for lots of things. We use them for the liver, for the brain, for the musculoskeletal system and joints. And we can use it for breast cancer screening as well. And it's actually a very effective test. And in general, the screening sensitivity of breast MRI, again, varies depending on the age of the patient and the composition of the breast tissue. But in generally, the sensitivity, the percentage of cases of breast cancer that exist that the MRI will find is much higher. And that's on the order of 90. Some studies even show higher than 90%. The false positive problem with MRI, which used to be a very big problem, has gotten a lot better with time. And so we're a little better off than that. One of the main problems with really kind of getting MRI wide exposure like we have with mammography is that it's a much tougher test to deliver and carry off. It requires an IV. It requires sedation, not sedation, but for some women, a little pill to get them sedated. And it requires to go in a very narrow tube, which some women find very disconcerting. And there are many, many fewer MRI units in this country. And it's also a much more expensive test. So when you look at all the pros of MRI in terms of its ability due to screening, it's not a test we're really in a position to offer to everybody. In women at higher than average risk, though, MRI is very potentially a part of what we described it as this tailored or intensive screening program. So among high-risk women, oftentimes MRI will be part of that screening program. Okay, so that's kind of one thing we do with the information. We can tell a woman, like, here's your risk level. Here's how we're going to look very closely after the breasts. Exam at least once a year, sometimes twice a year by a doctor. Making sure a woman has self-breast awareness, so she has new symptoms, she brings them to the attention, and then annual mammography in addition to annual MRI in certain high-risk women. There are some other tests, but none of them have really gotten to the point where they are able to be used as screening tests. Now, I'll say a little bit, with mammography, it's not just one test. There's something called 2D mammography, which is just the two-dimensional pictures. There's 3D mammography, which is kind of like a CAT scan for the breast. And there's also something called contrast enhanced mammography. And I think contrast enhanced mammography is kind of a mid-ground between 3D and MRI. And it's starting to become a little more popular. And to me, it remains to be seen how much that's going to be incorporated into our routine workflow here. So the other thing we can do with this information, because screening and intensive screening is important, it really doesn't do anything about whether something's going to happen. It just means you'll be hovering over it and hopefully find it earlier if you're in a high-risk screening program. The other thing we want to do, though, is to be able to offer actual preventative or risk-reducing interventions. That's really what we're driving at. How can we not only identify you as high risk and look after your breast closely, but how can we bring that risk level down closer to the average level of risk? I didn't know how to slide on that. There you go. I already said that. Sorry about that. Dr. Jaguar got me off course with his great question. Sorry. But here are our preventive interventions. It really falls into one of three categories. And I look forward to the day when lifestyle modification and pharmacology conspire to come up with even more interesting and innovative things in terms of micronutrients and supplements. We don't have great evidence on those just yet, but I think there will be increased attention and interest in that. There was a Dr. Jaguar, I hope when he comes back on, he'll probably be able to comment on, like there was a selenium supplementation prevention trial for men with prostate cancer a while back. And it didn't turn out to be true that it would be helpful, but I think there's a lot of potential in that direction. But for now, lifestyle modification is one focus that we have in the cancer prevention world and in the breast cancer prevention clinic. And I'm not a lifestyle modification expert. And if you ever saw how I eat or that I don't exercise, you'd see why. But really what it comes down to is kind of a clean living motto. Eat properly, exercise regularly, maintain a healthy weight, avoid excess alcohol. And we know that women that in large studies of groups of women that tend to do those things tend to come up with fewer breast cancers, not zero breast cancers, but fewer breast cancers. So it makes sense that if you're not doing those things, it makes sense to start to do them. And if you do, you'll have a much better risk profile when it comes to heart disease and risk for stroke and heart attack and things like that. So those are important things. And in the breast cancer prevention clinic and in the Center for Cancer Prevention and Wellness, I know this is a major emphasis as well. There are these medications that can actually help, prescription medications. I kind of basically lump them into this description as estrogen blockers. And they either block the effects of estrogen in the body on breast cells or block the production of estrogen within the body. And even though a lot of women, that might be in this kind of pursuit of lowering their risk of breast cancer might think that estrogen blockers wouldn't really help them because, say, they had a hysterectomy with their ovaries removed 10 years ago, or they're postmenopausal, and so they don't think they have estrogen. It is true to say that every woman does have estrogen. Even men have estrogen, because even in the absence of functioning ovaries, fat cells produce estrogen. So there is value in these drugs in preventing breast cancer, lowering the risk of breast cancer. And that's something that the Breast Cancer Prevention Clinic talks extensively with our patients in that about. And then finally, and not to be dismissing it, surgery is actually a very effective way to prevent breast cancer. Turns out it takes a very dramatic and extensive surgery, but it is effective at preventing breast cancer. And as a surgeon, I always want to make sure that the patients I send over to the Breast Cancer Prevention Clinic understand that surgery can have a role, but it's definitely not something that's for everybody. Here's the lifestyle modification, right? It's really what we all know we need to do, but it turns out that it's not just waving your hands in the air. This does have some effect. Unfortunately, we don't have a good way to quantify the effect. If you exercise twice a week versus 5 times a week, does your risk go from 17% to 11%? We don't really know that, but these issues are very important when considering that. So I wanted to do this. Consider you're in the risk reduction showdown. You see that? Notice I picked a picture of myself from probably like right when I got here 18 years ago.
Actually, I got muted and lost the video, but when I looked at this, I said, this is Brian in high school going to trick or treat as a doctor. You're looking pretty young there, buddy.
I still feel like I'm an imposter dressing up as a doctor sometimes, Jeff.
Right.
But that was, I think, my first employment picture. So I picked that one on purpose to kind of like, I probably shouldn't have told you, but I knew you were going to say something anyway. So, but in the risk reduction showdown, let's see a show of virtual hands. What do you think wins, medicine or surgery? What do you think is more effective at reducing breast cancer risk? Anybody weighing in there, Jeff, chiming in?
No, I don't know if I would be able to tell, but from the standpoint of the answer, I'm going to let you have that. If somebody really, really needs to have major risk reduction, surgery is a better option.
Do you want to talk a little about the estrogen blocking medications first?
So in premenopausal women, the answer is in an increased risk situation, and perhaps even if the risk is secondary to a genetic predisposition, there have been studies that have shown that tamoxifen can significantly, to the point of 45–50% lower risk, taken for 5 years. In the most postmenopausal population, tamoxifen, raloxifene, the aromatase inhibitors have all been shown to do something similar. But if a patient has a significant risk on the basis of a BRCA or other germline mutations,
I'm cutting you off there. I'm cutting you off there.
All right, you go.
That's good. So I think that's true, and I think that Dr. Jaguar is I guess I've known him 18 years now. He's very humble because when he says there have been studies done, he doesn't mention that he was really kind of critical to the Greenville community as being a part of like conducting these studies in the 90s and through the 2000s. These prevention studies that kind of showed us that these drugs could be effective. He was the principal investigator for our local cooperative clinical trials group. And so I think the Greenville community won't ever know, but they do owe him a debt of gratitude for really pursuing that along with his partners. They've been great about that. And as Dr. Jaguar was kind of going to start talking about surgery, I couldn't stand to have him talk about my area, so I had to cut him off. But the truth is, the medications by and large have a lot better acceptance than what I have to offer women. Way more women are willing to think about taking a pill than what I would have to offer. But what I do have to offer is a very robust, from a statistical perspective, a robust way to decrease the risk for surgery or just decrease the risk for breast cancer. So it unfortunately requires removal of both breasts, oftentimes combined with a reconstruction. So it's a lot of surgery to go through. It is a more difficult sell, but as Dr. Jaguar was starting to get into talking, you want to talk a little bit about the folks with mutations, Jeff?
Yeah, no, I mean, different mutations, and there's a lot more than BRCA, 1 or BRCA2, but some of the mutations have associated with them a much more significant risk of breast cancer over the course of a lifetime. And so it may be in a situation such as that the risk is significant enough that they're willing to go through this kind of more significant and morbidity producing, and obviously with reconstruction and everything, it's a long run, and it's a long jump, and it implies a lot of recovery time, but it may be worth it to have that kind of concern that's constantly over you taken away from you.
Yeah, and I think that I'm sure folks might remember from several years ago, Angelina Jolie was in the news, and she was diagnosed as having a pathogenic mutation in BRCA1, and we think that means that the risk of breast cancer among those types of individuals can be as high as 90%, like 60 to 90%. So what we can do with surgery is we can take that 90% risk, decrease it by 90%. So you multiply 0.9 by 0.9, and the risk comes down to like 8 or so percent. And then with a lot of the other mutations, the risk is more moderate, but still high, 40 to 50%. And we can bring those women's risk down into the low single digits. So for some women, that's the right decision. And it is definitely not for everyone. And it's interesting. I have seen the look of fear and the desire and the request for preventative surgery from women whose risk was, quote, only 20% lifetime risk. And remember, the average is 12.5%. So the other thing we try to communicate to women is the risk that they're quoted at any one point in time does not stay the same or go up as they get older. So if I meet a woman who's 40 and I say, based on the models, your risk is 40%, that's a scary thing for her to face. But if she can take the pill for 5 years and cut her risk in half, and now she's down to 20, after living 10 years, the actual risk will drop even further. So it's kind of like once you get that big number of lifetime risk, every year you live, you shed some of that risk. And so we try to make sure that we don't scare them into a surgery with a big number up front. Because as Dr. Jaguar kind of pointed out, it is not a trivial undertaking to have a both side mastectomy, either with or without a reconstruction. So I think that's the end of my slide set. I think to summarize, I think with breast cancer prevention, it really comes down to the individual and deciding how much you want to know, and also understanding that you may not want to know very much now if you're 41, but you might want to know more when you're 50, right? And so that this is an open offer and an open invitation to have this type of risk information session. You can decline at any step, but also come back to it at any step. And what you really need to do is learn about your personal risk level as it compares to average, and see how that makes you feel and what you think about that. And then for me, the answer is to go see the folks in the breast cancer prevention clinic, because I can still do some of this stuff in the office, but I'm not nearly as good or as comprehensive with the information as the breast cancer prevention clinic is. And so heading over to see Dr. Jaguar and the nurse practitioners that work over there is, I think, valuable. Even if you decide not to do any of it, you get the information. And then once you learn about all this, then you can decide what your approach will be, whether it's lifestyle, whether it's medications, whether it's a combination of things, whether it's you'll do this for a little while, and we see women in their 30s who still want to have, babies and breastfeed, and they go and do something, for part of it, and then they come back in their 40s and they say, now I'm interested in a bigger thing like surgery or an anti-estrogen, which obviously if they want to have more babies, they can't be taking anti-estrogen. So I always tell folks, and I'll end on this, what we offer here in breast cancer prevention is not a fixed menu. It's not the 3-course meal that you get at Rick Irwin's right before you go over to the Peace Center, where you have to get something for an appetizer, you have to get an entree, and you have to get a dessert, right? It is a buffet. And you can pick any part of this and pick and choose, and you can go back to the buffet. If you didn't do something the first time around and a couple of years later you want to do something else, you can make your way back and kind of take advantage of these things. So that's all I got.
Yeah, thanks, Brian. That's really, really good. You mentioned the family practice docs, and but more and more they are attuned to this, and just like OBGYN, we get more and more referrals from the primary care, the internist, the family practice docs, the OBGYN. So it's getting out there, and if you're not in the Prisma system, I mean, St. Francis has probably something similar to this. There's Gibbs. They're all very supportive of the Cancer Survivors Park. There was one question bemoaning the fact that prevention a lot of times is not covered by insurance and that sort of thing. I think we're getting there, but you're right. It's very slow to get there. So thank you for your talk and getting it all ready. Brian's also trying to get new residents to not be dangerous. July 1st is a time that you don't want to be in the hospital, but some people have to be, and they've got Dr. McKinley to oversee them. So we usually end these things with some kind of a quote or a poem, and so tonight I'm going to have a poem from Shel Silverstein, who you all know, probably you read The Giving Tree. Now you're maybe reading it to your kids or to your grandkids. But this is a poem called How Many, How Much. How many slams in an old screen door depends on how you shut it. How many slices in a bread depends how thin you cut it. How much good inside a day depends how good you live them. How much love inside a friend depends how much you give them. So thanks for listening, and tell a friend, and it'll be on cancersurvivorspark.org as a recording, and so let people know so that the word can get further expanded. Thanks again, Dr. McKinley.
Thanks, Jeff.